Welcome back to The Explainer. Today we are taking a highly focused, meticulously detailed journey through the exact textbook pathology, clinical presentation, and surgical management of lipomyeloschisis. And listen, my goal here is to clear up this concept completely, without skipping a single detail. We are going through this point by point, so you literally won't need to go back and scour the textbooks after we're done. Also, just a quick note on the visuals you'll see today. To keep things fresh and respect the original sources, we've styled our anatomical diagrams with a beautiful watercolor theme, keeping all the critical clinical facts exactly the same. Let's get right into it.
Okay, let's quickly map out our clinical pathway for today. We've got 1. Pathology of lipomyeloschisis. 2. Patient presentation and examination. 3. Diagnostic imaging and evaluation. 4. Goals of surgical treatment. And 5. The 12-step surgical technique.
All right, kicking things off with Section 1, Pathology of lipomyeloschisis.
So what exactly are we dealing with here? A lipomyeloschisis is essentially a subcutaneous lipoma that passes through a midline defect. But it doesn't just pass through one single layer. Oh no, it traverses the lumbodorsal fascia, punches right through the vertebral neural arch, penetrates the dura, and ultimately merges with an abnormally low tethered spinal cord. Think of it like an anatomical anchor. It's a continuous mass physically penetrating through multiple barriers, essentially pinning the neural tissue to the outside layers of the back.
Now, you really have to contrast the external and internal aspects of this mass to fully grasp it. On the outside, sure, you have the subcutaneous lipoma, but internally, this intradural fatty tumor is also known as a lipoma of the cauda equina. What's absolutely critical to understand here is that not only is the conus medullaris abnormally low, but the lipoma actually splits the conus medullaris right down the midline dorsally, usually at the exact same level as the bifid spine. And this dorsal split, the myeloschisis, can even extend upward under intact spinal arches.
Let's talk mechanics for a second, because there is a very specific, very dangerous mechanical complication that happens here. You get this thick fibrovascular band that joins the lamina of the most cephalic vertebrae directly to the bifid lamina. Why does this matter? Well, because this band heavily constricts the meningocele sac and the neural tissue itself. It creates a really dangerous sharp kink right in the superior surface of the meningocele. As you'll see when we get to the surgical steps, getting rid of this band is a massive priority.
Before we wrap up the pathology side, we need to talk tissue differentiation. The lipoma we're discussing is totally distinct from your normal epidural fat. If you were looking at it in the OR, you'd immediately notice it's significantly looser and much more areolar in texture. And just to put into perspective how common this specific pathology is, these lipomas account for a full 20% of all covered lumbosacral masses. That's a huge chunk.
Moving right along to Section 2, Patient Presentation and Examination.
Let's break down exactly how these kids are presenting in the clinic. The dominant presentation, bringing in about 56% of patients, is simply a visible back mass. The parents see it and bring them in. The next major group, sitting at 32%, presents primarily with bladder problems. And that, of course, is a direct functional result of that neurological tethering we just talked about. Finally, about 10% are brought in because of foot deformities, varying degrees of paralysis, or leg pain.
Now, when you're actually doing your physical exam, you cannot skip checking for associated cutaneous stigmata. You want to look for specific markers on the skin. We're talking port wine stains on the lower back, unusual patches of abnormal hair. And when you look at the extremities, check for clubbing of the feet, talipes echeverus. Other critical markers to carefully evaluate one by one include asymmetrical fatty pads extending from the midline, deep dimples, dermal sinus openings, or even little skin appendages.
But here is the crazy part. Get this, 50% of patients present with a completely normal neurologic exam initially, half of them. Most of these patients are brought in simply because the parents noticed that skin lesion. But, as a clinician, a normal initial exam doesn't mean you're in the clear. That tethered cord is essentially a ticking clock.
For the other half of patients who do actually present with deficits right off the bat, the absolute most common neurologic abnormality is sensory loss, specifically isolated in the sacral dermatomes. So if you're looking for that earliest clinical red flag of neural compromise, that is exactly where you look.
Okay, on to Section 3, Diagnostic Imaging and Evaluation.
And this beautifully rendered watercolor-themed MRI perfectly illustrates the internal reality of our physical findings. Look right where those yellow arrowheads are pointing. You can vividly see the lipoma extending down, literally exiting the spinal canal directly through the bifid L4 vertebra. You can also clearly see the abnormally low-lying conus medullaris. This visual right here is the ultimate confirmation of that anatomical tethering definition we started with.
So, what is your standard cannot-miss evaluation checklist? First up, plain lumbosacral spine X-rays. By definition, these are going to show spina bifida in almost all cases, though keep an eye out for segmentation anomalies like a butterfly vertebra. Second is the MRI, where you'll be looking for a high signal on T1 and a low signal on T2 to confirm that lipomatous mass. Finally, and please do not skip this step, every single patient needs a preoperative urological evaluation to clearly, objectively document any existing deficits before you even think about surgery.
That brings us to Section 4, Goals of Surgical Treatment.
The symptoms of this condition are primarily driven by two massive issues: the physical tethering of the spinal cord, which is especially dangerous during childhood growth spurts, and compression from the progressive deposition of fat. Therefore, the goals of surgery are strictly functional. Release the tethering and reduce the bulk of the fatty tumor. It is absolutely vital to understand this next point. Just doing a cosmetic treatment of the subcutaneous fat pad, that does absolutely nothing to prevent neurologic deficit. In fact, it can actually make later definitive repair impossible, so don't do it.
So when exactly do we operate? Well, the textbook clinical timing guideline is highly precise. Surgical treatment is indicated when the patient reaches exactly 2 months of age. If they present later in life, you operate at the exact time of diagnosis, no waiting around. Also, make sure to utilize your surgical adjuncts. Evoked potential monitoring is critical here to protect those neural pathways during the operation, and laser techniques are highly useful tools for these really complex resections.
We also need to be totally objective about the statistical outcomes here. Post-surgery, about 19% of patients will actually see their neurological symptoms improve. A tiny fraction, around 6%, will unfortunately worsen. But look at that massive middle block on the chart. 75% remain unchanged. Now, in the context of a progressive tethering disorder that gets violently worse as a kid grows, keeping a patient unchanged and stabilizing their condition, that is a massive primary victory for sure.
Finally, let's move to Section 5 and see how this all builds into the 12-step surgical technique.
We are going to rapid-fire narrate this so you see how it flows. Here are the first 6 steps for access and release. Step 1. Mobilize that subcutaneous mass as it funnels down through the deep fascia. Step 2. Open the last intact vertebral arch. You want to work from normal, healthy dura down into the pathology. Step 3. Identify that thick fibrovascular band crossing the widely bifid lamina we stressed earlier. Step 4. Section that band. Boom! You've just freed the dural tube and released that dangerous, sharp kink. Step 5. Taking extreme care to preserve the dorsal nerve roots, you incise the dura anterior to the dura-lipoma junction. And Step 6. Carry out a very similar incision procedure with the arachnoid membrane.
Now for the critical untethering and closure. Step 7. Continue those dural and arachnoid incisions around the entire extent of the tethered conus. Step 8. Safely untether the cord and placode. Now, slow down and pay very close attention to Step 9. Removal of the lipoma is intentionally subtotal. Yes, you trim it down as completely as possible, but you deliberately leave some fat behind. Why? Because you absolutely need to protect the dorsal surface of the placode from catastrophic injury. Better safe than sorry. Step 10. Reform the placode into a closed neural tube. Step 11. Close those pile margins. And finally, Step 12. Close the dura. If there's way too much tension, just use a fasciolotic graft.
Which brings us to a final pretty provocative thought. Let's say you execute a perfect, flawless, 12-step untethering. Do all the symptoms just magically resolve? Well, the sobering clinical reality found in the literature is no. While you can successfully halt bladder degradation and relieve that mass compression, conditions like foot deformities often just continue to progress regardless of the surgery. It's a really powerful reminder that while our surgical techniques are incredibly advanced, the neurological impact of a lipomyelomeningeal cell is profound, and it's lifelong. All right, thank you so much for joining me for this complete step-by-step explainer. Keep reviewing this material, and I will see you in the next one.